NGH mission is to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow caregivers, and translating science into clinical practice. I'd like to call this meeting to order, and at this time have a conflict of interest statement, that opportunity for each member to disclose potential conflicts and their belief they can be unbiased and able to participate, or that they elect to recuse themselves from the matter. Ms. Janet, do we have any public comments at this time? All right. You have your minutes in your packet from the May meeting. You've had a chance to review them. Are there any additions, corrections? If not, we will entertain a motion to approve the minutes.
So moved.
Second. Thank you. Been moved and proper second. Ready for the question. All in favor of approving the minutes, vote by the sign of aye. All opposed, ayes have it. Thank you. We're now on to old business, and we'll begin with Ms. Kathy Poole, who will give us information relative to hospital utilization and marketing. Ms. Poole, for the sake of clarity in terms of the things that we need on the agenda, our agenda can get long when we start adding, and I've heard several people say, well, can we have this? And I don't mind making sure we have information, but I would rather this report be quarterly and not every meeting. So if you could start thinking about what that might look like.
Yes, I can definitely do that. I was going to say next month for July, we would give the bigger marketing, government relations, PR overview.
Okay.
But I do have just some quick things I wanted to hit on. In front of you is an Invest Nashville booklet. So one of the things earlier this fiscal year we worked with Invest Nashville last year. This year we kind of expanded it to have a full chapter in their book. We've also had them interview Dr. Webb. He's been on podcasts with them. And then they had their Invest Nashville event last week. Unfortunately, because of hockey playoffs, it got pushed back a little bit further than it typically would be. But it was a great event, which we were a sponsor of. And so in this chapter, what we really talked about is we had Reverend Fuzz be a part of it, also Dr. Fair and Jen for the foundation was a part of it, as well as yourself and Dr. Webb, our CEO. And it just gives us a different audience. When we look at who we look at marketing-wise, it's obviously we want patients in the door, but the other piece of it is looking at who our strategic partners are in the city and who we can connect with from the business side of things, in addition to politicians and everything else. So I thought it was a very good piece. And I know Dr. Webb will mention something later on in his CEO report. Just wanted each of you to have a copy of the report. As far as utilization goes, we have, based on our strategic plan, to increase the average monthly commercial clinic visits 3% from 3,959 to 4,078. And I'm pleased to report right now we're at over 4,400 for those average monthly commercial clinic visits. We also have a goal to increase our average daily ER utilization 20% daily, so from 69 to 82. Since we implemented our no-wait ER, we are at 76, so we should have no problem meeting that goal by the end of the year. Also increasing the percentage of commercial insured patients from 21,500 to 22,000, so it's 3%. Obviously, as we go forward, we're going to want that to be closer to the 20%, but right now we are well exceeding that by over 4,000 visits. So we're sitting at about 2,700. And then, of course, our Metro employees. Utilization FY23 was 5.1% of our patients were Metro employees, and we have creeped up not quite to 5.5%. So slowly but surely, we're seeing a lot of impact from having our Metro Center clinic, the Bordeaux clinic, as well as the no-wait ER. And we are doing a lot of PR regarding the state incentive program, the no-wait emergency room, And then next month, it'll be heavy on the Nashville Healthcare Center urgent care that will be opening in the Bordeaux. Any questions?
Thank you for that information. Any other questions or comments?
I was wondering if you could put out a calendar or make that a part of the packet so we can know ahead of time. I know a couple of times we've had some things that have come up. I wanted to attend, but I was out of town or I've already had a meeting booked. So if we could possibly get some of those.
Yeah, Caitlin's
in
actually
advance,
done a
that would be
great job
great.
for the rest of the staff, so we will put it in a format to include it in next month's event. So,
Okay, thank you.
yeah, perfect.
Thank you, Ms. Poole. So the next item on the agenda, and I see Ms. Brown hasn't made it yet, but we do need to go ahead and approve it because they've already done the work on this CEO goals, and they have it in our packet here. And again, Lester Smith, that committee has already met and reviewed this, and this is the period ending June 2024. So you'll see that in your packet, and if there's no questions or comments, we'll entertain a motion on the committee's work there.
I read through it, and there's something in one of the emails about they still needed to meet to establish deliverables, or what is it? Pardon?
I'm sorry, the deliverables are for fiscal year 25. This one's complete and ready to be approved.
Okay.
It's the next year.
So this is
working
for the year that's just ending?
This one is for what ends today, for tomorrow.
Yeah.
So if I mentioned, since I'm on that committee, the materials we had available to us for the 2023 year end, we had to organize that quickly since they were way behind on the evaluation. And then we had very little time to go ahead and get 2024 together. And so we did add some things, but wanted to really, quite frankly, spend our time on what we felt was most fair to Dr. Webb and ultimately the staff to be able to create very specific metrics and criteria around the 2025 performance numbers, being that he could very, the year is what it is. And giving him something and say, hey, fix this in 30 days is not a very fair opportunity. But we wanted to also show that we were doing the work to make sure that we started outlining things within all of these different key areas to show that we are moving forward as a committee. So God bless you. So I think that that's something that's really important to know, that we are really focused on getting the right criteria, the right formatting, the right metrics, which involve, quite frankly, a lot of people in this room and their departments, to make sure that we give plenty of time, a fair assessment, and even some stretch goals back to Dr. Webb for 2025.
Committee has really dug in. I appreciate the work. We're getting back on schedule, back on track. We were years behind, and so to be at this space is really good. So I'll entertain a motion to approve these goals.
So moved.
Been moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye. All opposed, adopted. Thank you. We're now on to new business. We have 3 contracts we want to review. Finance team committee has also had a chance to look at these. Dr. Brown, you're recognized on the first contract.
Thank you, Mr. Chair. The first contract before you is Acre, Inc. That contract is a contract that we're submitting to the board. We had a previous contract with another vendor that didn't work out, and so we went to the runner-up contract. So these were bidded out previously, and so what we're asking the board is to approve the contract before them. It's a 3-year contract that we're asking approval on.
Ms. Smith, you're recognized for a financial report on this first contract.
Thank you. We discussed this in our committee. We did a deeper dive on each of these contracts in front of us to understand that this was a somewhat of a replacement contract with regard to the first contract and RFP that went out. The second place, if you will, is this group, and we had just some turnover that I think the first bidder could not continue in that capacity. So we're only able to spend 8 months in that contract, and basically felt like this was the next in line. And it's a ever so slight increase in the price, and also a 3-year contract. So our finance committee moved unanimously for full board approval.
Thank you. Any questions or comments? All right. Seeing none, I'll entertain a motion on the Archer contract. Moved and properly second. Ready for the question? All in favor, vote by the sign of aye. All opposed? Ayes have it. We're now on the second contract, the security contract. You recognize Dr. Brown.
Thank you, Mr. Chair. Garter World is a security contract. We currently have that contract for the security of our campus. This would extend the hours so that way we could have an unarmed guard at the entrance after hours to make sure that patients that are entering the hospital or visitors that are entering the hospital goes to the place that they should be going to visit their relatives or friends or whoever they're visiting at the hospital. So we're seeking an extension or a increase in the current contract to cover those hours of service that we need to keep the hospital safe and locked down.
Smith, you recognize for the Finance Committee report on this contract.
The Finance Committee also wanted to just add that this amount was not originally budgeted within the current service contract for security. This was identified by kind of the no-wait emergency room department addition, and feels like this is going to be more secure more secure for our employees as we don't want people roaming around the building. So our Finance Committee unanimously would move this to full board for approval.
Thank you. Any questions or comments? This is basically a third shift staff member?
Yes, and so we have 24-hour armed guard coverage throughout the hospital. So during the day when we're here, it's not a problem. It's just once after hours from about 6 to 6 a.m., there's only a person at that front desk, but they're not watching who comes in and go out. And so those people just have access to come in and go up or go wherever they want to in the hospital. So this person will ensure that they're not doing that, but it is a off shift.
Thank you, Dr. Brown. You've heard the Finance Committee report, and you've heard Dr. Brown's recommendation. I'll entertain a motion for approval.
So moved.
It has been moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye. All opposed? Thank you. And our last contract, Dr. Brown, you recognize.
Radiology Physics Associates, Inc. is they are a company that actually tests our equipment, make sure that when we make changes, that if there's a state requirement or something, that we're meeting all state requirements. They're a physicist company, so they test our lead aprons to make sure that they're properly handled and that they're protecting the providers and the staff. And so we've had this contract since I've been here. We went out to bid with it. We were paying them on a as-needed service basis, so we were sort of paying them monthly. We wanted to go to a quarterly payment, so that way in our AP we would have an expectation of knowing how much we were going to pay them as we move forward. But we've had them since I've been here, and they provide a great service. And this is the first time that this one actually has gone out to bid, which is a good thing. And so we got them back. They were the company that we chose during the bid process.
Thank you, Dr. Brown. Chair Smith, you recognize on this contract for finance report?
Yeah, so after conversation, obviously with Dr. Brown and Mr. Naramore, it seems like it allows us to smooth out a little bit the kind of the cash flow, so we're not having 1 month where it seems to be a higher influx of cost over the other. Again, we've heard that they do a great job They have been here a long time covering the nuclear medicine department. So with that, we moved unanimously as a finance committee to move to full board.
Thank you for that information. Any other questions or comments concerning this particular contract? Seeing none, I'll entertain a motion to adopt this contract.
So moved.
Second.
Ready for the question? All in favor, vote by the sign of aye. All opposed? Ayes have it. Thank you, Dr. Brown. All right, we now have the pleasure of a foundation report.
Good evening, Board. This evening, I'm going to talk a little bit about storytelling and the power of storytelling. So, as we all know, storytelling can evoke a lot of emotions, and it helps us to engage with our donors, and it does build loyalty to the organization. So I'm going to read you a story. This is the Stilts family, and they have a pretty impactful story. We recently found ourselves facing one of those most heart-stopping moments that every parent dreads. Our vibrant 12-year-old daughter, a whirlwind of energy with passion for softball, Girl Scouts, and gymnastics, she woke up feeling under the weather. Despite our initial skepticism, she's a tough cookie, but after all, her condition worsened, and by lunchtime, she had a very high fever and was sent home from school. It's a scenario all too familiar to working parents. The struggles to balance work obligations with ensuring that our child receives the care that they need. In our moment of panic, the quick path seemed to be the emergency room. Despite some initial reservations about the inevitable wait times and the impact on our work schedules, however, our concerns were swiftly alleviated the moment we stepped into Nashville General Hospital this past April. From the onset, we were met with unparalleled level of compassion and efficiency. Gone was the agonizing wait. Instead, we were ushered right in. Nurse practitioner Vicki emerged as our beacon of hope. Her expertise and warmness provided a sense of calm amongst the chaos. And it wasn't just Vicki. Nurse Megan, gentle demeanor and reassuring presence all made a difference during this very trying time. Turned out our daughter had the flu, but thanks to the no-wait emergency room at Nashville General, we were able to focus entirely on her well-being. Today, we are overjoyed to report that she's back to her spirited self, thriving in her endeavors. Our experience has left a mark on our hearts filled with gratitude for the exceptional care we received. Yet we are acutely aware that not every family is fortunate. That's why I employ all of you to join us in supporting Nashville General Hospital to ensure every patient receives the same level of compassionate care we did. Next slide. We've all been there. I know I've been there as a working mom with a son that always had ear infections and running back and forth to the doctor. Our no-wait ER was a lifesaver to this family. And having these types of stories, they build trust, and it builds transparency, and it shows the impact. And especially in the work of philanthropy, it's really hard sometimes to show impact, but having these types of stories, everybody can relate to this. Next slide. And then you can see Addie herself. You know, you can read what she said. I mean, this is a 12-year-old that now forever is loyal to Nashville General. Next slide. You'll always hear me say that when it comes to philanthropy, it's a team effort. So to gather these types of stories and to talk to these families, I work with our patient experience department, marketing, and I do work with my colleagues every single day. And we do training with them about recognizing these types of stories and how to approach families. So I just hope you were moved as I was and could relate to the story, because when it comes to philanthropy, really, this is what it's all about. Thank you.
Thank you, and thank you for sharing that.
I have a quick question, Jim. Thank you for the presentation. Sure. Do we have anything here, I'm not sure what's available to all employees, to, if they want to be able to directly give as a part of their paychecks into the foundation? Obviously, you know, you probably have a lot of people who live the work, who live the mission, and I think philanthropically might either, you know, want to give or take a tax deduction, something, whatever. They know they feel passionate. So I'd like to know that if you guys have anything where through payroll you can do these deductions, or at least through. Yes. Okay. Great. That's all.
Yes,
What
and
is our percentage of giving as employee population?
So I have to tell you, we have not done an employee campaign in a few years. But I will say that I don't know that stat, but I could get it for you. I can tell you that some people have been giving continuously for like 10 years plus. I mean, it's a very humble group here, and they love and they believe in the mission. So our formal campaign will kick off again September 1st, and it will be payroll deduction or one-time gift. Any other questions?
Jen, what is your annual budget, and has it been steady over the last few years, or?
Define what you mean by annual budget. You mean expenses, or do you mean gross revenue?
Gross revenue.
So I have looked at some of those numbers as benchmarks of going forward for fiscal year 25. So, you know, we have run anywhere from 250 to 300,000 a year in gross. But I'm looking at strategies to obviously increase that each year. So I'm still looking at those benchmarks and putting those plans in place, but they'll be ready for the next couple of days, July 1st.
What are your expenses running approximately?
So I don't really have that full data. Probably Bruce over in the corner will have all that data. So I really don't have it in front of me, just simply because we didn't have like really clear lines. And so we're building those in. So I will be able to tell you that with confidence.
If you were to ask us as a board, what is the number one thing that we can be helpful to you with regard to this foundation? What is that?
Share with me your connections, who you know. Serve as ambassadors as well for this organization.
And I would just, as a follow-up, I mean, I think that's the right ask. I'm sure the expectation at my level would be, then reach out to me, schedule a meeting, and let's have a conversation.
Absolutely.
Thank you for your report. We're glad to have you on board. You have hit the ground running, and you're doing some amazing work. Can't wait to see what the future looks like with our foundation.
Great. Thank you for your support, guys.
All right. We don't need to approve that. You have the quality report in your package. Dr. Williams, you're recognized.
You have the quality report in your packet on page 18, and I'm here to respond to any questions if there are any.
So I think the last time that we had this conversation on the quality report, Dr. Williams, there were a couple of things that you guys were going to follow up with us on. I think they were in the minutes, but I can pull those back up. But just wanted to see if you were able to give us a little bit more detail with regard to the dashboard itself and helping us better understand that. And one of the examples was a 75% sepsis and the compliance numbers. I think that Dr. Miller, you had mentioned some things as well. So I just wanted to follow up from that.
Let me first address the hand hygiene, which of course is just a pure percentage of times people wash their hands. It turned out that there was some miscommunication with the residents, and we have provided education both to the residents, and we had resident education orientation this week, so we think we've addressed that issue. We should see that go up, and then I'm going to ask Veronica to come up and talk to us about the challenges that we've had with sepsis. And essentially, that's a measure of implementing the sepsis bundle in a timely fashion.
Thank you, and good afternoon, Board. So my follow-up on one of the questions that was asked of me was, is this a nationwide struggle for hospitals? And it is. So in 2018, the sepsis bundle was changed from a 6-hour and a 3-hour bundle to a 1-hour bundle. And hospitals across the nation have struggled with that. I pulled our region, and so I have scores, and I won't say who they are, but 22%, 40%, and 67% is what you're seeing here in our community of hospitals around this 10, the 10 that are around us. And so in the month of May, our sepsis committee was reconstructed. I have my leaders of that committee. Amy Tavares is over there. She's our ICU director, as well as Ashley Mancini, who's supporting us with education. It's a multidisciplinary committee. It's providers, nurse leaders. We have frontline nursing staff, pharmacy, and lab, because you have a bundle of things that you are supposed to complete within that hour. We are falling out from fluid management and redraw of lactic acid. And so we're working on that strategically. They're looking at retrospective data as well as real-time reviews, and then we're also performing some mock codes for our sepsis alert. And so that's to get staff educated on what's required of them moving forward. That's about
Is the goal 75%?
75% compliance with the sepsis bundle. And it is a bundle of treatment things that you need to complete within that hour. And so if you look at just a few years ago, you had 6 hours. They had a 3-hour block, and they had a 6-hour block. You had that time frame to complete those list of things. It's been condensed to 1 hour. So you can see why hospitals are struggling to get all of those things met. And it's little things that you just, if you miss one, you're out of compliance. And so that's where we are. We're trying to get that 75%. Yes, sir.
So this is not a measure of ordering the sepsis bundle,
No,
but
sir. It's
how quickly
completing-
it's instituted when
Correct.
sepsis is recognized.
Correct.
Okay.
It's not even when it's recognized, it's once you
Complete the items.
when
Correct.
you start the fluid IV, when
Correct.
you institute medication. If any of those steps, there's a delay in the...
Oh, sorry.
It's a series of things. If there's any delay in any of those components, it pushes the whole bundle into the negative zone.
Yeah, I was just trying to distinguish between our doctors ordering the bundle.
Sepsis is a nurse-driven protocol.
Yeah, it's automatically,
Absolutely.
it's automatically implemented.
Okay, but at what point is it determined sepsis is present?
When you get back to labs, so if there's any delay in labs within that 1 hour, that will delay you starting fluid resuscitation. So automatically you're out. So it's a multi-component process that we're working on each of those components to try and get it in. But what we're trying to say is it just got moved from 6 to 3 to 1, and everybody in the community is struggling with meeting this particular compliance standard.
Do we know what the numbers of patients are for these months?
We can get them for you, Dr. Miller. We don't have those for you. Yeah. We can come prepared next time to dig as deep as you want to dig.
How about the EMTALA report? What drives us being out with that?
Well, I think what you're seeing, you're seeing red. And so if you look at the numbers, we're at 98%, 97, 98. Our goal is 100%. So they're auditing every EMTALA form. So say if a signature's off, if a box wasn't checked, that counts as that percentage off. We're not in necessary violation, but we're shooting for 100% documentation complete every single time.
I mean,
So I was really looking at this before, and I was like, we probably need to change it to yellow, because that doesn't really represent what you're seeing. You're seeing red across, but we're pretty high.
I mean, I'm assuming that these are patients that are not being denied care by our emergency
This
room.
is EMTALA documentation audit of the form that we've completed. We have to complete a EMTALA form on our transfers out. Or somebody, you see what I'm saying? So this is merely documentation. This isn't about the patient or what they wanted or did they stay. This is our documentation audit to make sure we're in compliance. And we're actually in the process of looking at that form in partnership with Dr. Williams and changing some things to make it easier. We have a very old form that needs revision, and we're working on that. But I think we need to change that to maybe yellow, because you're seeing red across there, but you know, red to me is we're 50%. We're 97, 98. We'll probably need to look at doing that moving forward.
I think the main question, Dr. Miller, is no, this is not a reflection on patients that we're denying care. It's just a piece of paper that documents what our transfers.
Yeah, I agree. Red does say that it's critical.
Well, our director of quality, I love her because she has attention to detail. She's like, if it's not 100%, it's red. So I haven't fought her on that. If yellow makes you feel a little bit better, it's still not 100. So we appreciate her attention to detail, and that's why we left it that way.
I have a question about, just, I guess, two questions. One about the actual format of this. We see it, you know, every meeting. So is this a format that we've created, or is this a format that's actually specific to, if we were to go to any of those other hospitals that you mentioned, no name mentioned, that is, would their formatting look exactly the same? Is that the first question?
It would probably, well, I know it would be the same indicators because these are required by CMS. Mm-hmm. Their determination on what's red, green, or yellow would depend on what their hospital decides. So as an example, you could go to Ascension and they may say, if we complete our EMTALA form 75% of the time, that's green. But we're holding ourselves to a higher standard. So that's where you would see the variation if you went from different facilities. But you would still see all of these indicators. These are all required by CMS.
Okay, and the last question I have is the willingness to recommend. So I've seen a couple red, but definitely below our targeted goal. It looks like 74%. Can you talk a little bit about that? I know we've had some conversation about that in the past with marketing and how those are measured. So just remind me if you don't mind. And then what are we doing to get this moving back the right direction?
Right. So there's other partners that might need to help me as far as action planning, because we do have an operational performance group that works on HCAP scores very heavily. Also, Tori Tate, who's our patient experience director, does rounds with our patients and has really helped us with a lot of service recovery. But I knew you were going to ask me that question or ask us that question. And so I did an analysis of other hospitals in comparison with us to willingness to recommend. And there are months that we perform better than them, and there are months that we are, just like you see, are some red. So I think there's some varying factors. There's factors I need the board to help me with. I need some inpatient room furniture, because I think that really matters. So when you look at it, like we get comments and stories about how great our nurses all the time, but I can't help that they don't have a recliner in their room for their family to sleep on. And so there's some things I could ask you all to help us with in regards to willingness to recommend. But when I pulled the scores for our other hospitals, we're kind of right in line. So it's not like we're performing at the bottom and they're all on top. It doesn't look like that when you look at it across the continuum. And that goes the same for staff responsiveness. I pulled that one as well. And it's the same phenomenon that we see. There's, actually when I look at staff responsiveness for some of them, there's multiple red on here. And so I think we're all kind of struggling with some of that. We do have a new call light system that we will be implementing later on this year that, we got approved for the 4%. I think that will help out because we're at a disadvantage in some of that. But if you all could help us get some capital, that would be really awesome for our willingness to recommend.
I think one thing that would help is if we could, again, have a breakdown of this to know what are the primary drivers for willing to recommend being low. So is it physical facility? Is it personnel? Is it bill?
I would have to, so we can bring that back, or there's another group that can bring that kind of drill down back for you, and I'm happy to speak to it if I get that information. The comments that I've read is about appearance. And so I can have the nicest nurse in the world, but if I'm not getting the amenities here that I'm getting in other places, which there are some, you know, it does impact our scoring. We good? Thank you.
Any other questions? We will try and bring some more detail like patient numbers, and you don't always get a comment, but there are some comments so that we might be able to give you some clarity on what is at the bottom of willingness to recommend. Yes,
Dr.
sir.
Williams, I'm struck by the consistent improvement in C-section rate. Does that reflect policy change, or, I mean, it's the best, you know, like 3 months running since I've been on the board?
I cannot say that that's a reflection on any policy change. I think that's totally driven by the physicians in that department have driven that performance.
You did
Sir.
have some, did you have some change in physicians?
Oh, yeah.
So we did have some change in physicians, but we started working on when the C-section rate was starting to kind of look, or we noticed, or the information was being given back to us that it was up. We started working on it. We have Mother, Infant, and Child Committee, and we started working on it and looking at that and changing some practices. So not necessarily a policy change, but practice change. And it was being looked at from the Meharry physicians, from their Meharry leadership, and they drove that change from their side. And on our side, ours is a new practice that started in February, and we're driving it from our side. But I think from the rate that you're seeing, there was work done through the leadership with the Meharry physicians, so it's doctor-driven. Okay.
I just had one quick question about just kind of overall, you know, clearly y'all are implementing some new practices. I appreciate the deeper dive here because, you know, again, some of us are not as deep in some of these specialties. So being able to ask questions and really better understand and having benchmarks are for me, very appropriate. And I appreciate that, the work that you're doing to help us understand. The question I have is really around kind of best practices. Is there a format for you as, you know, chief nurse to be able to collaborate with and find best practices for other people in your position throughout Nashville's hospitals? Because it feels like if it's a common problem, whether that can be identified at this level and or maybe, you know, shared experiences, maybe one that could draw attention to something that, quite frankly, if an hour is unreasonable, maybe that needs to be relooked at by a lot of people too. If there's something that your other hospitals are doing, maybe we should know about, or vice versa if we have a lot of success.
Sure. Well, I've just recently been nominated to THA's Quality Committee, and so I'll start serving on that for my year in August. But my nursing leaders have been involved in the THA Collaborative, and so they get some of their information there on best practices, but we do hope to see a greater partnership moving forward. I do have a call with THA and the CNOs around the city, and we bounce ideas off of each other when we have a problem at that call as well.
So this has been a very helpful discussion. I do just want to remind all of the board members that, you know, we are competing in the marketplace. And so we have a quality control committee, and it may be helpful if we add a board member. Is that something that we can consider?
We tried to do that, and the time that the meeting met conflicted with the board member who said they were interested, but they had a conflict at that time. So we're more than willing to have someone attend that meeting. Jen, I don't know if you know what, isn't that like the second or third Tuesday of every month at lunch or something like that? So we're happy to.
But that's when you do your deeper dive, right?
Correct.
Yeah.
Correct. I would also like to say, and I don't want to make any excuses, I mean, it should all be green. But if you look at our performance, like, you know, we haven't had a MRSA infection. I don't know how far we did, but we haven't had a MRSA infection since October. We haven't had, you know, a C. diff infection. I mean, those are the things that are improving lives. Those are things that So willingness to recommend is important, but I want you to see the great job that we're doing as a community hospital and some of the things that make a difference in people's lives and their outcomes. So I hope the board appreciates the significance of some of the other metrics on this sheet.
Yeah, thank you for really breaking that down for us. If there's no other discussion, I'll entertain a motion for approval of quality report.
So moved.
Second.
Been moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye.
Aye.
All opposed? Thank you, Dr. Williams. And Dr. Williams, you are...
Still here.
Yes.
Just to report on the bylaws committees that we haven't had one meeting. There was someone who expressed an interest. Was it you, Attorney Brown, that wanted to come to the bylaws meeting? There was someone on the board.
That was me.
Was it you? Okay, so
I asked when it
so
was.
the bylaws committee will be meeting on July 10th. I believe it's at 4 o'clock. I'll get you the exact. And it's going to be that same time every month until we come to a point where we think that we can have a vote again. And it's my understanding that only one board member can attend at a time. Okay.
Oh, shucks.
Any questions for Dr. Williams? Thank you.
All right. I'll just stay here in case there are any questions on credentials.
All right. Dr. Burley, you're recognized.
Thank you. Well, we just had two initial appointments, recommendations from the Medical Exec Committee. One is for Nathan Kane, DO, Specialty in Surgery, and this is a provisional status to the active category. The other one is Allison LaFoon, and her specialty is cosmetic surgery, and she would be coming in as a consultant. So those are the two initial appointments to the medical staff. There were also two initial appointments to non-medical, and that would be Catherine Lodgent, PA in emergency medicine, and Van Stroman, family nurse practitioner in internal medicine. Since we have moved to the two-year credentialing, we have a number of reappointments, so I won't read all their names, but they've all been reviewed by MedExec. No issues, no problems have been noted, and they've all been referred on for approval. And I don't see any reason why we shouldn't go with that recommendation at this point.
Dr. Williams, do consulting surgeons have surgical privileges in the hospital?
Yes.
And do we do some cosmetic surgery in the hospital?
We do have some. I think we actually have two plastic surgeons on the medical staff. I do want to also say we're in the process of transitioning to a paperless system. We have all but about 45 physicians who've actually gone on and attested in the new system. So we hope in the next 3 to 6 months we'll be completely paperless on our credentialing process. That's why you're seeing so many names, is that we're getting people on to our new credentialing system.
Any other questions or discussion? You have the report in front of you, and I'll entertain a motion to approve.
Second.
Moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye.
Aye.
All opposed, ayes have it. We've approved that. Thank you. All right, so Bruce and Ms. Smith, you all are recognized for our finance report.
Good evening, Mr. Chair. First item on the agenda is our 2025 fiscal year budget. I think we actually approved the original budget way back in the March board meeting. And then last month, we just provided an update with the recommended 59.55 support from the city. And so this is the final budget with all the numbers updated. We did increase a few of our self-generated revenues up to just above $61 million with our other revenues. Just a point that we discussed in finance, we are going to lose about $5 million this 25 year there was one-time money that was paid to the hospital, not just our hospital, but all hospitals. So we could not count that going forward. So when you hear in a minute that we have a positive margin of about $5.6 million for this year through 10 months, about $5 million of that is one-time funds that were paid, disproportionate share dollars, all hospitals, although it certainly benefited Nashville General this year. So we can't count on those, and that's why you see the budget numbers for 24 versus 25 and that additional funding dropping. Because that was one-time money that we received from Medicaid, MCOs, and others. So, it would have been great if we had gotten a higher support number for the charity work that we do here from the city, but we squeezed the numbers, and I think we're going to be able to make it break even. You see a small operating loss of $320,000, but that's basically a break even from a cash flow standpoint. And Dr. Webb and the ELT, with effort, we think we can make these numbers work. So that is our 2025 budget. We're producing about $4 million more self-generated. Unfortunately, we're going to miss about $4 million in our other revenues. And the other discussion at finance was about contract labor. And contract labor has been a difficult for every hospital across the nation, certainly in Tennessee. Every year that I have budgeted for that contract labor to decline, it has not done that and caused budget difficulties for the hospital. We did talk a lot about recruitment. We're doing a much better job as a hospital in terms of recruiting new staff. Dr. Brown discussed the fact that we are having to do 2 orientations a month instead of 1. We've got enough people to fill those 20-25 slots at each setting. We just have to be able to keep those staff here, get them trained into our system, and then we can release those people in those contract labor spots and hopefully reduce that contract labor. But every time I bet on that, we've gotten stung. And if we're successful, and the contract labor drops back to $10 million, then we'll make $1 million next year instead of breaking even. So those are just sort of the high points. The hospital's obviously counting on generating additional net new revenues at the Bordeaux Imaging Center and the Metro Center, where we have some pretty busy physicians who joined us in February, and now we're going to have them for the full year 2025 fiscal. So that's just the high points. None of the expense numbers changed from what you saw the prior time. We just had to update a little bit our own self-generated revenues and some of the state dollars in order to balance. So this is our proposed 2025 final budget. And it's basically a break-even budget at the 59.5 support from the city.
Bruce, again, what was the difference between what was requested and what was funded?
It was about $4 million,
Okay.
about $4 million.
Lower than what was requested?
Correct.
Okay,
Correct.
thank you.
It was about a 3% increase over what we received from the city last year, or for the year we're in. All right.
Okay, any discussion or questions on the budget? We'll need to approve that. All right, seeing none, I'll entertain a motion to approve the budget.
Second.
Been moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye.
Aye.
All opposed? Thank you. You're now recognized for the April report.
Okay, for the month of April, like I just mentioned to you, we've had a very good 10-month run here at the hospital, certainly helped by some of those one-time funds, but also growing our own volume and revenue by almost $5 million through the first 10 months of the year compared to last year. So just rough numbers, a good admission month, 225, budget was 218, so we beat that number. Same in the observation area. Our length of stay in the hospital inpatient setting has been excellent all year. We've gone from a 4.6 average last year to 4.0. So we get paid the same whether they're here 5 days or 4 days. So the quicker we move them through, the better it is for us. Less nursing care, less expense on the hospital, and we still get paid the same. So that's a win. And the longer patients are in hospital, the more bad things that can happen sometimes. So moving them through is great clinically and financially for our patients and for the hospital. Our ER volume was down a little bit this month. This is the month in April that we actually instituted the no-wait ED. I know our numbers have been up in May and again in June, so we hope that stays with us. Emergency room admissions were above budget, even with missing the visit numbers. Our med-surg visits in the clinics, extremely high in April, over 4,200 clinic visits. Compared to 3,500 in the budget. We did not have the Metro Center Clinic in our budget projections. We didn't know they were going to be part of the system when we did this budget last year. And they do see about 800 to 900 patients a month in that clinic setting. Surgery cases on inpatient and outpatient were better than the budget, and our cath lab numbers were right on the number. Deliveries were up slightly for the month. But have trended down this year compared to last year overall. And our case mix was mild at about 1.37 for our discharged admissions in April. For the financial results in the month, our gross revenues were about 5% below budget. Most of that is just because when length of stay drops, you have less charges in terms of gross revenue. But our net revenues at $5.01 million we're about $160,000 behind budget, 3%. Our other revenues, I told you about some of those one-time funds and so forth that we've been receiving this year. So far exceeded budget in that category. And so for the hospital for the month, we had $13.4 million of net revenue to deal with, which was $2.4 million better than the budget. Our expenses were about $1.4 million higher than the budget, including that clinic, including Bordeaux and the imaging center who are just getting spooled up. So expenses were high in salaries. They were also high in the supply area as we outfitted those locations with their startup supplies, equipment, small equipment. So those are the outliers for the month. But still, with all that said, we had a $240,000 positive margin for the month. We were supposed to lose $740,000. And for the year to date, we have a positive margin of $5.6 million. Been a really good year for the hospital through 10 months. So that's it for April. Questions, please.
Questions or comments?
What is our occupancy? What is our capacity in the hospital?
Well, and I'm going to tell you from the finance guy's standpoint, I think we have probably 94 patient rooms, give or take, single patient rooms. We're licensed for 150, but if we don't like to double up patients, so we could probably get up close to 95. But occupancy, it has been recently low 50s, and I'm talking fannies in the bed, Dr. Miller, So whether you're an inpatient or you're an observation waiting for conclusion one way or the other, I would say high 40s to low to mid 50s is our standard, and that's what we staff for typically on a given day.
So we have capacity for 94, but about 50% of that is staffed.
I would look at my nursing leader back there, but I would say in that 50 to 60 is probably what we staff for.
That's what we staff for. And
Yeah.
It's really not 90 because you're counting NICU.
Right.
Special areas
Yeah.
that can't admit to every place, including the 7th floor.
Mm-hmm.
Okay.
Does that help? Chair Christy Smith asked me before, while we were in finance, what was our greatest opportunity, and I told her that we have significant capacity in this hospital and our OR and on our floors. We can take care of the business, and if we grow that ED business, we can take care of it, and our marginal costs are low. So we have opportunity there if we can grow volume in our outpatient areas and in the hospital inpatient setting.
To grow that, would that require more contract labor?
I don't think so. I mean, we're making some dents, Dr. Miller. I mean, we are recruiting more effectively. I do think that when we have Cerner live as a clinical system, it will be easier for Veronica and all of us to maintain our staff. Because right now they're working sort of one hand tied behind their back, no disrespect. It's very manual system that we operate in. And when you pull somebody over from one of our competitor hospitals, they feel like they've gone back in time 10 years. So they have to be committed to the mission to stay.
Bruce, I'm a little confused about your answer about the average daily census, because if you look at the year to date, it's about 35.
That's inpatient, that's not observation.
No, that's
Okay.
adding
Yeah.
inpatient plus observation. Average daily census year to date is 28.3, and observation average daily census is 6.6, so that's like 35.
Yeah, well, I'm not sure that I agree, but I see that
Well,
that's
it's just-
listed there. Yeah.
If that's wrong in here,
Yeah.
then we need to correct it, because
Yeah.
that's kind of where it's been for the last few years.
Point taken. Fair.
What's budgeted and what we actually spend on contract labor for the last 2 years, or last 3 years, has not been close. You suspect it's going to be closer to what you're predicting in the budget on contract labor this year?
Frank, Mr. Chair, that's what we actually talked about in finance, that in the years where it jumped up from 3 million to 8 million, and we budgeted for it to drop back to something like 5 or 6, it went up to 10, and it created huge budget issues for the hospital. So I think I was asked at finance, do I think it will go down? I hope it will go down. I'm not willing to bet that it's going to go down substantially. And the other side of this is we're in the middle of a significant clinical build right now. So our nurses and our ancillary staff, they are not only taking care of patients, they're also building and learning a completely new clinical system. So I don't think it's going to go down until we get to December or January when that system goes live. I don't see it until then, because we're kind of all hands on deck right now in the clinical ancillary space. Veronica could correct me, but that's my concern. Yeah. 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 That's why I left it kind of flat. If it comes in at 10 or 11 million, we could have a celebration, because we'll be even more profitable than current.
Any other questions or discussion for our finance report? Seeing none, I'll entertain a motion to approve. I'm sorry, Ms. Smith, did you all approve this in Finance Committee?
We did.
Thank you. I'll entertain a motion for approval.
So moved. Second.
It's been moved and properly second. You ready for the question? All in favor, vote by the sign of aye.
Thank you.
All opposed? Thank you, Bruce.
Thank you.
All right, we'll now have the CEO's report. Dr. Webb, you're recognized.
Thank you, Mr. Chair. I do want to just make a brief comment about the concern with the inpatient volume. There are a couple of things happening. First of all, we see and schedule close to 500 patients a day on this campus. That doesn't include the inpatients. That's ambulatory, that's ER. Those are scheduled among our clinics. So some of it's in our clinics, some of it's on this campus. So there's a huge amount of volume that circulates through. Our goal is, through our community care team, is to keep people out of the hospital. If we were to start to eliminate some of that preventive care that we're providing to that large population, we'd see our inpatient volume inflate. What that would do is that would cost you more money to operate the hospital, and it would be a very inefficient operation. The second thing is you have to be, in order to penetrate the entire population, you've got to be in a location where it is conducive to attracting that population. So I'll leave it at that. Okay. So speaking of a new hospital, just a quick update. We know that the mayor has been busy with a number of projects. We have not, to this point, gotten feedback yet on his committee that he wants to put together to help to locate space for a new hospital. So we're continuing to wait on that. We're going to continue to work with our community stakeholders and make sure that our patients are getting the health care that they need. And when the mayor's office is ready to meet, then we're going to meet and address the space, the location. So I'll continue to update you as we hear more from the mayor's office. I understand that there could possibly be some movement after the budget has been approved. So maybe that'll be a little more optimism at the next meeting. I do want to run through a few things here. First of all, I want to introduce to the group and the board Ms. Christy Lewis, our compliance officer. She's right here. She has joined us. She is very credentialed in the area of compliance, hospital compliance, and has a wealth of experience. We're looking forward to having Ms. Lewis on board. Dr. Brown, who you saw a lot of earlier, it was announced that 2024 Nashville Business Journal is recognizing Dr. Brown's for the C-Suite Award honoree. He'll be featured in the 1024 special edition. Congratulations to Dr. Brown. Our pharmacy director, Ms. Evelyn Henson, was selected as one of the 25 pharmacists that will participate in the Tennessee Pharmacy Association Emerging Leaders Academy. I don't know if Ms. Henson is here, but congratulations to her on that recognition. Last week, our CIO, Chief Information Officer, Ms. Melanie Thomas, moderated a health and education panel with Invest Nashville. That's that magazine that you have there, that the special event, and our own board chair, Chairman Frank Stevenson, was one of the panelists and did a great job. So thank you all. I will be joining Nashville as a part of its leadership Nashville class in the coming year. So I'm looking forward to that. I would like to express thanks to Dr. Southpaw. Is she still here? Okay. She has made herself available, along with her team, to meet with our team here. We've had 2 meetings over the last couple of months, and we're scheduling monthly meetings. We have one coming up in the next few days. So making good progress, addressing a lot of the issues that we're faced with among the 2 organizations. But just wanted to express thanks to her for making herself available and her team. Also would like to recognize Dr. Fair and her team for the work that they've done with Meharry and their research division, which is a new area for us, but it has really worked well. We have clinical trials in place and working collaboratively with Meharry also in that respect. We continue to move for the goal for the gold initiative of our Cerner implementation. We have 172 days before implementation. We celebrated in our cancer care program the 16th annual Dr. Robert E. Hardy Survivorship Celebration on June 2nd. And we will have our commission cancer accreditation survey in July. And we've had that for over the last 80 years, and at the highest ranking among the accredited bodies under the American College of Surgeons, who perform that accreditation process for us. We are also now in the period for Joint Commission survey, and that will be occurring. We think it's going to be occurring around October of this year. Urgent Care Center at Bordeaux is scheduled to open the week of July 13th. That's as you know, Bordeaux was a healthcare desert up until the point that we introduced the Bordeaux Center, Healthcare Center. So this will also give them after hours on Saturdays, 9 a.m., 6 p.m., Sundays, 12 noon to 6 p.m., opening of an urgent care center. So that should be certainly a major change in how they go about seeking their health care. And lastly, the Diagnostic Imaging Center is scheduled to open around the latter part of July. So I want you to put on your calendars July 31st, 10 a.m. for an open house and the ribbon cutting for the Diagnostic Imaging Center. The delay there was through the state required licensure that we had to undergo. So we're looking forward to opening the imaging center with all of the major services that will add to the community as well. So that concludes my report. Happy to answer any questions.
I just want to start out and say I commend you guys for working with the meetings at Meharry. I think, you know, as a board member, I know some of us have obviously, you know, had a lot of talks around this, I think, and it's just such an important relationship. And while we may not maintain our autonomy, excuse me, and our mission, I think it's clear to me that you feel like it's important for this community as well. And so I appreciate the extra effort that you make and that's made by our staff to make that, you know, make the effort at those communications. And so thank you for doing that. I appreciate that.
How much, the urgent care center is going, what are the hours of that going to be?
It will be 9 a, 6 p. on Saturday, 12 noon, 6 p. I'm sorry. 9 a to 9 p. on Saturdays, and on Sundays, 9 a to 6 p.
And during the week?
It'll be open the hours during the week, regular hours, 24? What? Monday, yeah, Monday through Friday.
Monday through Friday, it's just walk-in evening hours for our staff. Thank you so much, Christy. So urgent care, you said it right, Dr.
Yeah.
Webb, is Saturday and Sunday. There are walk-in new appointments during Monday through Friday with the regular staff that is at the clinic. So the urgent care piece is really Saturday and Sunday, as he
It's
described.
to cover the clinic so that there's still
Thank you so
availability during those hours.
And will the imaging be available all those times?
The imaging will be available during the times that yes, it will be open during regular hours as well as the hours of the urgent care.
Any other questions or discussion for Dr. Webb? Okay. Just a couple of things I want to share in terms of what I've been doing. I had a chance to participate in the joint committee training with the staff here. Man, it took me back to SAC COC, which is what we go through for accreditation at the university setting, but it shared a lot of good information that opened my eyes up to a lot of things. Obviously, as Dr. Webb indicated, I had a chance to participate in that panel with Invest Nashville. Good questions. I had a chance to kind of sow a seed about the importance of this hospital in particular, the support that it deserves from those city leaders that were present, including a new hospital. So I had a chance to put that in the atmosphere, so that was good. I also met with Dr. Webb one-on-one in our CEO and chairman opportunities. So I appreciate the work and kind of where we're going and the direction, and things have settled a little bit. I met with Dr. Webb. I said, Dr. Webb, it's good to have a meeting, and it felt like the first one where something wasn't on fire, right? It just felt good. I mean, it was just good. So we're moving in the right direction. I want to take upon a personal privilege to thank our counsel, our residential lawyer, who has done an amazing job. I believe this is her last meeting with us, and she is not going to rejoin the board, and she's done an amazing job. So will you all help me celebrate her work with this? Every committee she has been on, she has dug in and just really did the hard work. So we appreciate you tremendously. All right. Let's see. Is there anything else? How much time you got? We can keep this going a little while longer. You got about 15 more minutes?
Yeah, I've got 20.
I'm kidding. We're done. I'll entertain a motion to adjourn. Have a good day.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.